Let's talk about some other treatments for respiratory patients or asthma COPD patients in the 911 setting. So we talked about treatment for asthma, acute asthma attacks. So, we talked about oxygen increasing that FiO2. Talked about short-acting beta agonists such as albuterol. Talk about long-acting beta agonists such as formoterol. Anticholinergics that we have on the truck like ipratropium or Atrovent, and leukotriene receptor agonists such as Singulair that your patient might be on at home. We've also talked about COPD treatments. Again, oxygen, shoving oxygen into them, and those beta agonists and those anticholinergics, and throwing some steroids on top of the mix. That methylprednisolone, that solumedrol. But what are some other treatments that we have kind of in our toolbox that you might see out either in the 911 setting, you might see in the critical care setting, or you might see there in the hospital? Well, there's CPAP and BiPAP, so continuous positive airway pressure, and BiPAP is not so continuous positive airway pressure. We'll get into that a little bit more in the next unit when we talk about ventilators and ventilator settings, the difference between CPAP and BiPAP. But for right now, we know that positive airway pressure. So we're providing positive airway pressure. This keeps our airways open. This keeps our alveoli open, keeps them recruited. Less respiratory fatigue, decreases work of breathing, improves our VQ ratio. So we've got an issue here, not with the perfusion side, but with the ventilation side. And here we're improving our ventilation side. We're improving air going in and out. And again, we're recruiting alveoli. There are some risks that go with CPAP and BiPAP. We'll talk about, we'll just kind of focus on CPAP. There's some risk with CPAP. There's hyperinflation. So we push too much pressure in there. You can pop some alveoli in there. Worst case scenario, you can kind of pop a lobe and cause some barotrauma there. And then there's research that says the use of CPAP with asthma patients with COPD patients increases hospital stays compared to just medication treatment of the same condition and the same patient presentation. If we are to reach for other medications aside from our albuterol, our Atrovent, our solumedrol, which is kind of like our big three, maybe our mag sulfate, what can we reach for? Well, we can go for epinephrine, we can go for epi, we can go for aminophylline, maybe terbutaline, or maybe even Heliox. So we'll go through each one of these four in turn. So epinephrine you should be familiar with. So super alpha agonist and also beta agonist. So beta 1 and beta 2. Here we're looking for the beta 2 effects with epi in a respiratory distress patient. This is a serious respiratory distress patient that we're going to be giving this to. We're going to give it IM, intramuscular, 0.3 to 0.5 milligrams, or in the cases of stridor, so not just wheezing, but stridor, we've got this whistle sound on the way out, we've got upper airway swelling, we are nearing respiratory arrest, we're nearing end organ failure, so we can nebulize epi. Depends on your agency's protocols. The protocols I know of and the ones I'm familiar with, you take 1 milligram of 1:1 epi, mix it with 3 mils of normal saline, and then you nebulize that. It's kind of contingent on your patient being able to to breathe and nebulize their own epinephrine. You could put it in an inline nebulizer with a BVM as well, or we could give racemic epinephrine. So racemic epinephrine is just D epinephrine. So if we think back to our chemistry courses, this is just a different kind of isomer formulation of epinephrine. So you might have racemic epinephrine, you might have just straight 1:1 epinephrine. Either way, we can nebulize this and or give it IM. The IM version is just going to be your 1-to-1 normal epinephrine, or we can nebulize 1-to-1 epinephrine or nebulize racemic epinephrine. There's also aminophylline, or theophylline is the the trade name. You're definitely not going to see this on the truck. They're not on ambulances anymore. You might see it in the hospital. This is a pretty old drug in terms of all things. It is an IV bronchodilator. It is not a beta agonist like albuterol. It's kind of its own classification, but it is a bronchodilator. It's given IV. When it was given in the 911 setting, when it was on our trucks, it was given as a medication of last resort because it has a very narrow therapeutic index, so very easy to underdose or overdose a patient on aminophylline. Again, you're not going to see it on the trucks anymore, but you might see it in the hospitals. Just know that is an IV medication, that is a bronchodilator, and it is not. It's not a beta agonist, but works as a bronchodilator. Another old medication that you won't see on the trucks, but you'll probably see in the hospitals is terbutaline. It's a beta-2 agonist, just like albuterol. It can be given IV or it can be nebulized, usually given IV, but again, it's pretty old. There are a lot of side effects to it, so they've pulled it off the trucks, but you still might see it in the hospital. Now, the last one I want to talk about is Heliox. You're probably not going to see these on the trucks. You might see them on a critical care truck, maybe a critical care pediatric truck, especially these are used on pediatric patients and infant neonates a lot. So Heliox is part helium, part oxygen, and it mixes the two. So we can go up to 80% helium, which leaves for 20% oxygen. We don't want to go below 20% oxygen because, well, room air is about 20% oxygen, so we don't want to be depriving you of any oxygen. But we are adding helium into the system, and this gets into laminar flow and turbulent flow. So we want to increase laminar flow, and we want to decrease turbulent flow in our patients, especially with asthma, especially with COPD. They've got a lot of turbulent flow. So turbulent flow is where the flow of, if you think of a liquid or that air is just kind of bouncing from wall to wall to wall to wall to wall to wall to wall. Laminar flow is just a straight line, point A to point B, nice, smooth airway wall. We have really good laminar flow, no turbulent flow. When we have an asthma exacerbation, when we have COPD exacerbation, we have lots of turbulent flow. So Heliox increases laminar flow, decreases turbulent flow because helium has a really low specific gravity and lowers airway resistance. So if you've ever, kind of inhaled, sucked in a helium balloon and your voice raises really, really high, well, that's because you've just increased your laminar flow and decreased turbulent flow and decrease the specific gravity of the air going in and out of your system. So we're still delivering oxygen, just in a more efficient manner. Again, this is used a lot for neonates, a lot for infants and pediatrics. Not so much for adults, but you might see it on critical care trucks, and you will definitely see it in pediatric ICUs and definitely in neonatal ICUs. If you have any questions, concerns, comments, or cuss words, please let me know.